general topic that's of particular interest to me for a variety of reasons. Let me see. You know, both Alzheimer's disease and sleep, and their interplay with each other, and it's something that I'm confronted with quite a bit. Originally, I started out doing behavioral neurology, and then started to do more sleep. I remember the first time I went to a major national sleep conference. Heard a lecture where somebody was telling about how the most important thing that led to institutionalization of dementia patients and Alzheimer's disease was sleep. And at first I thought it was just one of those self-serving things, but in fact, it turns out to be a very big factor in the clinical management of patients with Alzheimer's disease. The other thing that occurred to me is that I was talking the other day with the nurse practitioner I work with, who sees a lot of new patients and with me, and it seems that I asked her today how often, when she sees people who come to see us for a new patient, comes to see us with a memory problem, how often do we also deal with the sleep issue? And I thought she was going to say maybe 25, 30%, but she thought it was maybe closer to 50%. Those are the patients who come in with a first-time complaint, where they're seeing a specialist with a sleep disorder, with a memory disorder, and they also have a significant sleep problem. Most commonly insomnia, obstructive sleep apnea, things that warrant some treatment and management, and in fact interact with their initial problem of memory complaint. Sometimes it's just a coincident problem. Sometimes it's actually the main issue why they actually came to seek help. So I think that this interplay is oftentimes important. Now, this is a slide that I'm sure everybody's seen these, or variations of the slide, particularly this group, lots of times about Alzheimer's disease. Looking at the original descriptions, though, it's also worthwhile noticing that early on was this acknowledgement about sleep problems playing a role in these descriptions of patients, these very early patients with Alzheimer's disease. And the role, there's another slide that everybody's seen here, I'm sure, but the goal here is to, in particular, not just to worry about the sleep problems down here, which is more of a clinical management problem, but also the role of sleep in these early phases of the development of Alzheimer's disease and Alzheimer's pathology. I think that what I'd like to do here for this group, I mean, eventually what I'd like to do is get right into the part about what is this thing about the bidirectional nature of sleep and Alzheimer's disease, and what are the factors that are involved, and then maybe talk about the role of some particular sleep problems, such as I've listed here. People have looked at duration and also specific problems with insomnia or sleep apnea, or even restless leg syndrome. The Rem behavior disorder, we really won't talk very much about. This it's much more peculiar to, I think, problems with Lewy body dementia and the so-called synucleinopathies, and maybe talk a little bit about management and how this implicates itself into management. I think it would be helpful, though, to sort of outline the major sleep areas or sleep issues that get looked at, and then we can look at the interplay between these and Alzheimer's disease, and then look at the specific problems, sleep problems. And what some of that I'd like to do is just talk a little about their different components of sleep, because the ultimate question is what are the things we're going to look at? Are we going to look at sleep as a whole? We're going to look at the various components of sleep. Is it REM sleep, non-REM sleep that's most important to look at? Is there a circadian rhythm system involved with sleep? Is that the issue? And so I just want to briefly go through this list and see what we have here. Well, this is from a sleep lab, just a polysomnogram, which is ultimately the gold standard of sleep and sleep measurement. Now, for practical purposes, lots of studies don't use this, and as one sort of moves away from this gold standard, the information will deteriorate, and that's just a logistical problem that needs to be dealt with. Sleep itself is traditionally and almost for historical reasons, divided into these major components. This is based upon these sleep studies. And I'm not going to go into the details of these, except to say that we usually think of sleep as composed of either REM sleep, which is down here, or non-REM sleep. They're not very creative with their nomenclature. And there are some key features of each of these elements. One of the things I'd like to point out here in this N2 sleep or non-REM N2 sleep is there are some interesting features such as spindles and K complexes that we see here. The N3 is sometimes also referred to as slow wave sleep. REM sleep is the more typical sort of dreaming sleep. And both non-REM and REM play important roles in normal physiology. And so it's not surprising that there's some sort of interplay with cognitive impairment and dementia. All of that is usually distilled into this sort of a little display here, this little hypnogram. Hours are sort of displayed down here and different levels. Typically, REM sleep is sort of offset here in is by a different color in this particular diagram, and different levels of non-REM sleep are displayed here. There's an actual pattern to this, which I'm not going to go into great detail here, but even gets altered even by things like depression can alter this in a characteristic way, this sequence of events here. The other aspect about this is the concept of sleep need. And there have been a lot of studies, which I'll briefly refer to some of them in a little bit, about sleep duration and risk for cognitive impairment and dementia. And this is sort of based on a meta-analysis, trying to grab the whole of this sleep need. The way this is generated is that you can see each of the different stages of sleep are laid out here. And age is down here, goes up, this particular one goes up to 55, but things kind of continue in this general pattern with additional aging. The SWASO is just wake after sleep onset. So you can see that, certainly the major changes occur here in the first 20 years or so of life, and then things more or less start to level out. This slow wave sleep, or N3 in particular, tends to diminish with aging. REM sleep may decrease a little bit, and is generally thought to decrease a little bit slower with the progression of aging. The elderly, the very old people, tend to have no slow wave sleep, actually. And there are a lot of explanations for why that may happen, but that's just normal aging. The point here is that there's also this general average of how much people sleep need, which has always been a problem. There's no real good hard way to establish that. The American Academy of Sleep Medicine comes out and says that it should be 7 hours. It's one of those consensus statements, not really based on hard evidence. Certainly in the general population, there's a bell-shaped curve, and some people seem to do perfectly fine on less sleep. Some people do perfectly fine on a little longer amount of sleep. If this were a live audience, it's likely that this group follows this bell-shaped curve. And when we talk about the value of sleep duration as predictors of cognitive impairment and perhaps even the risk for Alzheimer's disease, there's no evidence that changing people will make any difference. In other words, if you have a short sleeper and they're at risk for developing certain medical problems or cognitive impairment, do you change that risk by inducing them to have more hours of sleep? So there's this concept of the different components of sleep, the sleep stages, the different REM sleep, non-REM sleep, and the roles that each of them may play, because they are somewhat different. I hadn't mentioned that REM perhaps is more involved in monoamine replenishment. It's more oxidative repair perhaps that goes on during slow wave sleep or N3 or non-REM sleep. But there's also this other component here, which is the circadian effects. uh, which also need to be adhered to, because these things will change in aging. They change in with Alzheimer's disease for a variety of different reasons, which I'll try to go through quickly. But anyway, this is just a model, a cartoon, sort of trying to illustrate this concept of the circadian rhythm. Certainly, there's a large input here from the retina, and so this whole system is very sensitive to light input. And there's specialized cells in the retina that then convey information to the hypothalamus. And there's this SCN nucleus, which in turn feeds back down through the sympathetic chain, feeds back on the pineal gland and produces melatonin. And it's this SCN is the master clock keeper for our body. And things go awry. This SCN, as I'll show, starts to falter. There's an additional cell loss involved with the progression of Alzheimer's disease. The particular cell type involved in this in the retina also shows particular cell loss. There's just things that with normal aging that occur. Cataract formation produces yellowing of light, and it's actually the blue light that triggers this system, and therefore just cataract formation will make the whole system much more fragile. So there's several factors which occur both with Alzheimer's disease and in particular with normal aging that will make this whole system much more fragile. And it just translates into this sort of so-called circadian rhythm, which is synchronized with our circadian core body temperature rhythm. So it's one way that people like to measure these things. Which, while we're at it, it's also interesting that just using this as a model, that normally this is sort of in the middle of the day. This is sort of also our peak functioning time, whereas this area, which generally occurs at night, this is when the core body temperature falls. There's also a drop off in function. People don't function quite as well. That's why shift workers have so many problems. It's why perhaps, although attention is not always paid to it, if people are serious about doing serial cognitive testing on any patient population, there should be careful control of time. So you're not comparing people at one level of their circadian rhythm to one level of their circadian rhythm to another. They're just not going to be comparable. And the other point I wanted to point out is that there's a lot known now about the neural centers, nuclei that control sleep. And they bear some bearing because some neurodegenerative disorders, in fact, are reflected in changes in these various neurotransmitter systems. These represent here sort of the key ones, and some of them are cholinergic. In particular, the acetylcholine ones in the PONs that are particularly involved in Rem sleep. There are two major, my understanding, there are two major cholinergic sources in the brain, and one is by the basal forebrain, which people have obviously studied in the context of Alzheimer's disease, and also in the brainstem that's involved in sleep. And so it shouldn't be surprising, which I'll come back to in a minute, that with the progression of Alzheimer's disease, one can see the progression of changes in sleep, and in particular, progressions and changes in Rem sleep. Then there are a few other clusters of monoamines, norepinephrine, serotonin, dopamine, and histamine in the tubular mammillary nucleus. The other one, which is not really well depicted here, is the system that's involved in the lateral hypothalamus, the orexin system. There's been a lot of information. Orexin's involved has projections to all of these systems I just mentioned, the monoamines and controlled to the cholinergic neurons. But it also projects more widely. And it's really gained its notoriety in its implication in the sort of narcolepsy, but it's also been involved in addition to sleep. It's been studied in terms of feeding behaviors and even cognition. Um, all of this is balanced out by this system over here, in the more anteriorly, more more GABAergic predominant part of the hypothalamus and the ventrolateral preoptic nucleus. But I just wanted to point this out, that a lot of this also is affected as people with aging and also with the development of neurodegenerative disorders affect these systems. And then there's also the lymphatic system, which certainly early on was thought to be sleep related, and perhaps maybe more non-REM sleep related. That's very important in clearing away various toxic factors. How much of it is circadian related or how much of it is specifically sleep related can be debated, but I think that it's still a key factor that needs to be considered when, specifically when one talks about sleep disorders. So that's just sort of the background, and which is just make it a little bit easier as we move forward in terms of make some sense out of this, I hope. So I've said that there's this bidirectional nature, and some of it's reflected in this, that there's been some correlation between the amyloid and its impact on sleep. So these arrows here, that it does have, there is a relationship apparently between the amyloid and its impact on REM, certainly REM sleep and other aspects about sleep. We can see certainly a decrease in REM sleep and a decrease in non-REM, particularly that slow wave sleep that I've mentioned before. We can see it's apparently has an impact on other sort of factors involved in sleep, including the EEG modifications. But it also is this opposite system, that sleep disorders themselves are thought to have an impact on amyloid production. Some of this is thought to be indirect, that is, sleep disorders affect their toxic effects, some of it presumably by inflammatory changes. In particular, in addition to sleep disruption, there's a lot of emphasis placed on the intermittent hypoxemia, since one of the major sleep disorders that we encounter is obstructive sleep apnea, and that carries with it both sleep fragmentation and disruption, but also intermittent hypoxemia, and that in turn has a very toxic effect, and is thought to account for quite a bit of the disruption and increased production of amyloid. So we have this sort of two-phase, two-way model here, and which we'll talk about. Now, I already talked a little about this circadian rhythm system, and very briefly, there's, I guess, I repeat what I already said, but there are several ways in which this system starts to fall apart with aging, and with additionally thought to be related to Alzheimer's disease. And so people examine all of these different features, ranging from the more age-related changes that occur just from having cataracts that can impact on this, at least in theory, but also its effect on that whole system, that impact on the retinal cells that are particularly implicated in this feedback system. And so it's not uncommon that we'll see people having these sleep disorders and circadian rhythm disorders, as particularly as disease progresses, which I had mentioned that orexin system before, and indeed there seems to be This has not been as satisfying in terms of looking at it. This is just the orexin. This is actually from a slide that I've used to talk about narcolepsy, showing the loss of cells in narcoleptic patients. But the point is that it's drawn a lot of attention, but there's been no good, clear correlation that I'm aware of. Although the orexin is implicated in cognitive function, there's never been demonstrated in Alzheimer's patients any clear correlation with loss of orexin cells and the development of Alzheimer's disease. And we talked already about this lymphatic system and its role and its relationship to sleep, and it's also its importance in presumably in reducing the risk of neurodegenerative disorder. So I wanted to spend a little bit of time talking about some of these sleep disorders and some issues that have been looked at. The first thing I wanted to talk about was the duration and looking at sleep duration, which is something that people have looked at quite a bit. I forgot, this is just a slide about the changes in sleep that occur with Alzheimer's disease. Just out of order, I apologize for that. But and I think we've hit upon some of these things, the particular things that have been associated with Alzheimer's disease. As I said before, this decrease in REM sleep and the slowing of REM sleep and a decrease in slow wave sleep. The REM sleep thing is particularly attractive because of the cholinergic linkage and the cholinergic involvement in maintenance of REM sleep. And there are people who've been proposed for a long time that you could probably map out the progression of Alzheimer's disease by looking at the changes in REM sleep, the rapid eye movement sleep that occur. Sleep becomes more fragmented in patients with Alzheimer's disease. And these are the sort of changes that have been seen with patients with Alzheimer's disease. But there's more napping. And it also had not mentioned this, that even if one looks at the morphology, as I said before, in the non-REM sleep or N2 sleep in particular, a little different than the slower sleep we've talked about before, there are the presence of these spindles. And one can actually also map out some changes in spindles in their frequencies, and their little, for spindles themselves are these very short bursts of high frequency, relatively high frequency changes in the EEG. And you can see changes in this deterioration in this spindle with progression of the disease as well. Now, back to the point I was making for, was to look at issues related to sleep duration. As I said before, normally, the official norm is 7 hours for adults. As I said before, I think that has to be taken with a little bit of a grain of salt. It's interesting, though, that large population studies, 7 hours plus or minus a little bit always tends to be the sort of sweet spot, and I think I'll show some of that. There are a lot of things, however, that can impact on sleep duration and how much one sleeps at night. And one of the things, the cautions about looking at some studies is that some studies, most studies, I think, will want to look at 24-hour sleep. And whereas on occasion you need to be careful because some studies will look at nocturnal sleep. So if you slept, the point being is, if you sleep 6 hours every night but take a 1-hour nap, how do you classify that? And I've noticed that there's some variation in studies how people deal with that information. Some of it's dealt with this one way or the other. Uh, there are also these other things that will play a role in how much people sleep. So it depends on how one ascertains the information. Uh, in addition to the impact of medications, diseases, um, other kinds of work schedules, but things like seasons, the seasonality is in one role. So in general, you'll find that most people tend to sleep perhaps a bit more in those short day months, uh, say December and so forth, whereas um, spring and summer, oftentimes people will sleep a little, their sleep need is decreased a bit. Um, there's also been even some recent studies showing that different parts of the lunar cycle can be associated with different amounts of sleep need. Uh, and anybody can actually do that if you're one of those fans of Fitbits or one of those, which are reasonable, certainly in terms of looking at total sleep. Um, the sleep will change just in terms of the lunar cycle. Um, so all these different things, mood has an impact on sleep duration. So all of these things, in addition to specific sleep disorders, will have an impact on sleep duration. Nevertheless, it's people, maybe because it's easy to look at, something that you don't necessarily need sleep studies to do. You can gather this information just by doing various sorts of inventories, which is oftentimes what's done. And there have been several sort of summaries, systematic reviews of this thing, of these items, and and there are two kinds of things that come up. One is just looking at cognitive impairment, and the other is at looking at uh, uh, risk of neurodegenerative disorder. Um, and usually the difference comes up in people comparing short sleepers to long sleepers. Uh, Short sleepers, how does one define a short sleeper? Can vary sometimes. I think most often, most studies may use 6 hours. People needing less than 6 hours of sleep a night are considered short sleepers. 6 hours, presumably most of them should be 6 hours per day per 24 hours um, time frame. And the other is the long sleepers. And very often 10 hours is used. Sometimes people will use 11 hours. It's interesting in sleep medicine and dealing with sleep disorders, usually the 11 hours is is usually most commonly the cutoff. But for these studies, most often it's 10 hours. One of the things that comes up from a lot of these studies is in people look at large population studies, they're more often likely to come up with short sleepers than long sleepers. I think oftentimes long sleepers are recognized as having some sort of pathology and probably get treatment. Whereas short sleepers, and I'll explain in a minute, short sleepers are different than people with insomnia. Uh, and and um, and so uh, so short sleepers, maybe I don't think they come in complaining of oh my God, I only need 5 hours of sleep a night. Occasionally we get those complaints, but usually we don't. People usually go with it, uh, unless they're sleeping 5 hours because of insomnia, which we'll talk about in a little bit. So in the general population, you're more likely to see short sleepers than long sleepers. Uh, you're also, and the other problem with these types of analyses is that you never ask the question about why is somebody a short sleeper or a long sleeper. Sometimes they may be, most commonly short sleepers become short sleepers because of stress and anxiety. And they're not distinguishing a short sleeper from a short sleeper who's sort of an acquired short sleeper versus a natural short sleeper, if you would. Similarly with long sleepers, most long sleepers oftentimes have additional medical problems, additional other issues that need to be addressed or should be addressed. But ultimately, all of these studies usually come up with U-shaped curves, meaning the short sleepers and the long sleepers both have more problems. And some of these studies have to do with the risk of Alzheimer's disease or just cognitive impairment. And usually it's the long sleeper. Most studies, I think, lumping them together when people do systematic analyses of all of these studies, long sleepers tend to do a little worse than the short sleepers. There was a recent, which I don't have here, there's a recent study, population study from China that suggested, tried to track this down and look at patients who developed cognitive impairments, and they studied these patients in waves, 4 waves, separated by each wave by a couple of years, a year or two, and showed that short sleepers predicted that at the next wave that they would start to see some cognitive change. But it also worked the other way, that the cognitive change predicted the change in sleep need as well. So I don't think it was very conclusive in straightening out this bidirectional nature or question of sleep and Alzheimer's disease. So most studies get these types of U-shaped curves. And it's not just for cognitive impairment or risk of dementia, but also has to do with other medical issues. When people look at cardiovascular risk or just risk of death of all causes. Well, what about insomnia? Now, insomnia is different than sleep deprivation. There may be some overlap, but they're different. One of the biggest differences is the typical sleep-deprived patient. And if I took one of you and just sleep-deprived you, kept you up all night, one of the predictable things is that you become sleepy. Whereas insomniacs, the usual insomniac, most insomniacs, by the standards that we usually measure sleepiness, are not sleepy. They may not feel good during the day, but they're not sleepy. In other words, they're not falling asleep. When we do various kinds of measures of sleepiness, they fail to show that they're sleepy people. So they're not sleepy people. So there are differences, and there've been a variety of studies, again, looking at this, and the bottom line is that insomnia itself is considered to be, even though Alzheimer's disease is oftentimes associated with disruptions in sleep, insomnia itself is also thought to be a risk factor for sleep, for Alzheimer's disease. And as I said before, getting back to my work with my nurse practitioner, this interaction between insomnia and Alzheimer's disease is fairly common. Most of the insomniacs that we see, either in the dementia patients or just in the general population of patients who come to see us just for their insomnia, not for their memory issues, the biggest culprit is usually stress and anxiety. So, ultimately it's this sort of thing that insomnia has a direct impact on the development of risk for neurodegenerative disorders and Alzheimer's disease, or is it really that insomnia has its role because of all these other factors, its relationship to anxiety, depression, increasing risk for high blood pressure, increasing risk for metabolic problems, which in turn create a risk for developing Alzheimer's disease. That's not clear. So this just the other thing that's drawn a lot of interest, in part because we see so much of it, is the issue of obstructive sleep apnea. And this is just a model. I'm not going to go into any details about what obstructive sleep apnea is, except to just say that it's a sleep-related disruption in breathing patterns. And in general, there are two major concerns usually about this. One is the disruption in sleep and the sleep fragmentation. And the other is that associated, because of this breathing issue, there's an intermittent hypoxia that's associated with it. And both of which are thought to perhaps play a role at risk for subsequent problems. And so sometimes there's debate about which is more important. I should also say that there's well, there, as I said before, certainly we do know that obstructive sleep apnea is a risk for all sorts of cardiovascular disease, and certainly is a risk factor. In addition, because of this, is thought to be a risk factor for neurodegenerative disorders, certain neurodegenerative disorders. In particular, it's a risk for cognitive impairment and Alzheimer's disease. I should also say that sometimes I do want to make this distinction. Obstructive sleep apnea is a factor in causing cognitive impairment. It's also a risk factor for the subsequent development of dementia. And it's not necessarily the case that the mechanisms are the same, and or they may or may not. But sometimes it certainly is a risk for both, and what the role of these are needs to be addressed. I should also say the research is oftentimes complicated because we don't know, we people in sleep medicine don't know what are the real important features about sleep apnea. How do we measure the severity of sleep apnea? Is it the number of events of breathing disruptions per hour? Are we measuring these events in the proper way? We use the measurements we use, the standards that we use, the tools that we use were developed like 50, 60 years ago. And just basically on somebody's dining room table, a group of people got together and sort of arbitrarily came up with these rules of measurement. Right now, and we have two different standards for measuring severity, the numbers of events of a number of events per hour, the severity of sleep apnea by using those standards. Maybe we should be measuring the severity of the hypoxemia that occurs, the drops in oxygen levels that occur. Maybe it's the changes in the autonomic responsiveness of the individual that should be measured. And it's not clear how we measure this. And one of the things that's happened is that the field is in a sort of a bind, because recently there was a review triggered by CMS to answer the question, is there a benefit from treating people for sleep apnea? In addition to those people, in addition to simply treating people's sleepiness, but is there, and maybe getting rid of snoring, which is usually a benefit to the bed partner, but besides that, is there a benefit? Are you going to prevent cardiovascular disease? Are you going to prevent recurrent stroke or heart attack? Are you going to prevent or reverse the risk for developing cognitive impairments in the elderly? And those studies have not, it's not that they've shown, there's been a failure to demonstrate the benefit outside of simple symptomatic relief. And even though it does place patients at risk for all of these problems. So I should just say that that's just a problem in the background. And part of it is that, are we measuring the right things? And different studies will oftentimes measure different things. But I should go back to finish up my thoughts before I get to this. But there is a clear-cut role in this. I think that some of the studies suggest that the more toxic component for the putting people at risk for subsequent impairment is the intermittent hypoxia that's associated with these sleep apnea patients. And something we don't take in consideration when we measure clinically, when we look at the severity, and maybe we should. There are other sleep disorders that we encounter. One of them is Restless Leg Syndrome, which is a clinical disorder, just this urge to move legs that occur at night, and usually occurs more at night than during the day, and it's usually relieved by movement and moving around, and it's been associated with some changes in iron metabolism, and certainly the biggest links have been with renal failure and iron deficiency have been linked with this. Although it's intriguing because if one looks at large population studies have looked at this, there seems to be this association between restless leg syndrome in an individual and risks for developing a whole host of other medical problems, which again, if not directly, will indirectly place people at higher risk for developing cognitive impairment later on. I said I wasn't going to talk about Rem sleep behavior disorder, but that's a dream enacting behavior that's thought of as a disorder of REM sleep, and it's thought to be a particular marker. It can be associated with a variety of different things. And what happens is as people develop this, they basically act out their dreams. Because normally during REM sleep, you should be paralyzed, and they lose the system, that ability to become paralyzed during REM sleep, which is an advantage, because if you're paralyzed during REM sleep, you don't act out your dreams, and these people basically act out their dreams. And it's thought to put people at considerable risk for developing a synucleinopathy, most commonly Lewy body dementia or Parkinson's disease. We don't typically see this in Alzheimer's disease. I know that there's heard some evidence that that maybe this can also be related to CTE independently of synucleinopathy. But in general, I think clinically it's generally thought to be a marker of a synucleinopathy, unless there's some rare focal lesions that have been associated with this, and it can be triggered by medication, certain medications, and that's why it's of interest to us. The last thing I was going to talk about was just the management, which is a more practical issue, and even with those involved in research, it's a major issue in managing patients, particularly as the disease progresses. And frankly, I think that the best way to manage these patients is to address it early. And I usually at the very beginning, when we start to take care of patients with Alzheimer's disease, usually address the concerns about sleep, that we need to address it early on, and take advantage of it. The shifts in circadian rhythm are oftentimes a problem. So people are sleeping times that would probably be better for them to be awake, but certainly being awake when they should be sleeping, and the rest of the family wants to sleep. So that becomes a problem. And there are many factors that can contribute to this. And I think the earlier that they're addressed in the management, the better, probably usually it is. The worst thing that happens is it's not brought up, and then all of a sudden the family's in crisis because they can't cope. Because what happens is the family doesn't sleep at night, and then they become sleep deprived and they can't function. So these things have to be addressed early. And, there are all these medications that are available, which I'm not going to go into any detail. It's always disappointing because if you read all the reviews about using these various medications, these are the ones that people talk about, and at the bottom they always say, well, but it shouldn't be used in the elderly demented patients. The only one here is this new class of medications, these dual action orexin receptor agonists that work on that orexin system. And in fact, the first of these, the suvorexin, actually has been gotten the nod from the FDA that it's okay to use in patients with Alzheimer's disease. So there is some promise along those lines. So I think we'll stop there. May have a couple minutes left. Got started a little late. I apologize for that. And maybe, are there any questions or anything? But I did want to point out that sleep is an important issue in this interface with Alzheimer's disease. There is a bidirectional source of this going back and forth between changes in Alzheimer's disease contributing to sleep problems, changes in sleep problems perhaps contributing to the Alzheimer's disease at a biological level as well as a practical management level. And I've always thought of this, as, by the way, as being a sort of an opportunity. I think that, when we see sleep patients, we should ask more about memory complaints. When we see memory patients, we should definitely ask more about their sleep problems. So then I will stop and see if there are any. I don't know if you have time for questions or not.
Yes, we have time. We can stay a little longer if everyone's available, but thank you for this presentation, and I'll open it up for anyone who has questions.
Hey, Sandy, that was thanks for the great talk. I just have one question about assessment. We talked a little bit about yesterday how they now come in for sleep studies where they're required to stay overnight. I was wondering kind of what movement there's been in terms of being able to complete these kind of at home with kind of the advent of technology and all that.
Sure. So right now, from a practical standpoint, the one that we do most commonly now is we do these home sleep tests, but they're really home sleep apnea tests. So that we can do home. Patient comes in, picks up the equipment, takes it home, comes back the next day, and that's fairly easy. It's not doesn't measure sleep, only measures breathing parameters, airflow, excursion, oxygen, pulse rate, things like that. It's not a measure of sleep. There are a lot of wearables available now, some a little better than others, that can be used. And there are various studies that look at those. When there's always a trade-off, because with the wearables, there is some deterioration. There are some attempts to develop systems that actually record EEG data, so they wear various apparatus over the scalp. And it depends also on how one analyzes that data, because some of the data is, if you have the raw data to have a trained sleep technician score it is one thing, but usually they have their own algorithms. So in answer to your question, it's doable. There's oftentimes some drop off in information.
Thanks.
It depends on what the question is. What you're after.
I believe Marcia has a question. We can't hear you.
Sandy, that was a great talk. I could talk to you for hours. So my question is, in epilepsy patients, we're beginning to record sharp wave ripples, and they're really not recordable without indwelling electrodes. But in your experience, they occur predominantly during slow wave sleep as opposed to REM sleep. And with a lot of these disorders, the amount of slow wave sleep that people are losing is maybe greater, and maybe they're trying to get more slow wave sleep. So can you maybe talk about, what's going on with respect to advancements in surface electrode technology that maybe we can start to be able to monitor for sharp wave ripples during sleep without indwelling electrodes like we currently do? Is there anything going on in that area?
Basically improving the sensitivity is what you're talking about of surface electrodes.
Yeah. So we
yeah,
can detect sharp wave ripples, because now you have to use, epilepsy patients with indwelling electrodes to really look at these fast oscillations implicated in consolidation of memory during sleep.
Yeah. I don't know. In terms of the technical aspect about that, improvements in that type of technology, I don't know enough about the technical aspects about measuring those ripples to know about that. I know that, it's interesting. There are, what we do clinically, there are tweaks over the years, but the way we do sleep studies, although it's something that people have been looking at, the way we do sleep studies and the way we measure sleep is people, if people came now and they said, oh, let's measure sleep and develop a system for measuring sleep, and had all the tools that we have now in terms of computer and software, they would never do what we do. I mean, it's somewhat archaic. I mean, a lot of these measurements, they're based on systems based on a page. The paper was a certain width, so, and we look at sleep in 30-second epochs, which is kind of artificial. So to answer your question, I'm unaware of any change in technology. It would be fascinating to do. It'd be fascinating to look at.
In my research, using indwelling electrodes in rodents, I'm finding changes in sharp wave ripple function in the prodromal stages of Alzheimer's. And when I look at your discussion here, so many of these sleep disorders shift that balance of slow wave sleep away. And if you are thinking that the sharp wave ripples and the lymphatic system and these things that are occurring during this deeper sleep are being disrupted, then you're not clearing debris, you're not consolidating memories, and all of this is going to result in cognitive impairments with this, and then maybe sleep disturbances, because now if you're not getting enough slow wave sleep, you try to sleep more to make up, to get that necessary slow wave sleep.
Well, I mean, those are both interesting questions, because it also has to do with the way that we measure slow wave sleep. The way that we measure slow wave sleep is based upon the predominant frequencies and the amplitude. It's the only stage of sleep where the amplitude of the waves plays a role. So 75 microvolts is the critical amplitude. So now somebody may have the same distribution of frequencies, but they maybe fell to 50 microvolts, which is what happens with normal aging, is the amplitude drops. And so the debate is that what should you measure? In the clinical setting, we're sort of stuck with these rules, and so we'll most of that gets defaulted to oftentimes stage N2 or N1 of non-REM sleep, and we know N3 disappears.
Right, and we know with ripples, as far as encoding and as far as consolidation of memories, greater amplitude ripples are associated with better memory for events. And so amplitude is really important in transfer of information, and just having the frequency without the amplitude is it's half of the recipe. It's I hear you.
And I also wonder there have been studies in the past which I haven't looked in a while, but where people just deprive patients of N3 and see what or deprive them of REM sleep and they used to do studies looking at memory functions, the various kinds of memory tasks, and REM deprived people or slowly sleep deprived, particularly the REM. They would do studies that were early on. There were studies where they would REM deprive patients and show that it would lead to some impaired memory. The problem is that there's a stress between, if you put people in a lab and wake them up every time they slide into REM sleep, you're putting a lot of stress on the organism, either people or rats. You're putting a lot of stress on them. So it was hard to make those distinctions. I think it's a fascinating but complicated area.
Yeah. Well, thank you for a great talk.
So, do your rodents, your rats, right? Do
Yeah,
they sleep
rats.
well?
I haven't monitored their sleep. Behaviorally, they seem a little more anxious than my wild type rats as far as their activity patterns are concerned. But I haven't monitored them for duration of sleep or amount of slow wave sleep versus REM sleep. I could, I have them implanted with chronic indwelling electrodes, so I could actually do that if I wanted to.
It'd be interesting. And how long do you monitor them for? Over what length of time?
Some of them I have implanted for up to 3 months, so I can certainly do 24-hour monitoring. It's awesome. Most of the studies I do are an hour or so in duration, and I look at them during periods of immobility, and then I have another model where I look at them in their home cage where they are in sleep. So I do both, but never more than an hour or two in a session, because I'm doing recording from them during the day, and they're on a dark light cycle, so I'm actually disturbing them from when they would normally be sleeping. So
right.
I don't like to disturb them too long because I'm causing them stress.
Okay, I'd like to open up if anyone else has additional questions. Please ask now if you are able to. And Dr. Auerbach, do you have your email address so that individuals can also reach out to you if you feel?
Sure. Well, I don't have it on here, but it's just S. Auerbach without the H at bu.edu.
I did get a question if you can make the slides available.
Sure.
All
How
right,
do I
does
do
anyone-
that?
You can just share it with me and then I can send it out.
Okay.
All right, well, thank you again for taking the time for presenting for the ADRC lecture series. Again, if anyone has questions, I've put Dr. Auerbach's email in the chat. The slides will also be available after this, and the recording will be available on YouTube as well. All right. Okay, thank you, everyone.
Okay.
Thank you, Dr. Auerbach.
Thank you, everybody.
Thanks.
Um,